Two or more levels are multi-level cervical disc replacement. The main aim is the preservation of the motion segment. It provides physiological range of motion to the adjacent segment and likely to prevent non-union pseudoarthrosis. Advantages is preservation of the range of motion, prevention of the surgical steps, as we have seen, having accurate midline verification, symmetrical decompression on both the sides, minimal drilling, maintaining the integrity of the end plates, which is important to prevent complications later on, appropriate size of the implant, and central placement. Decompression at the index level, that should be prioritized. Discectomy and end plate preparation at all the levels to be done before the placement of the implant. Appropriate size implant trail has to be ensured when adjacent level is being prepared. It is important to ensure the stability of the first implant. Any additional pressure on the compression of the cord manipulation has to be avoided. Contraindication, as we are aware, advanced spondylosis, osteophytic disease, arthropathies, severe osteoporosis, and any preoperative instability. The complications known are subsidence, expulsion, displacement, kyphotic deformities, residual radiculopathy, heterotopic ossification, and patient factors. So this is one current update of the current practices from general spine surgery, where there are various studies which meta-analysis has been done in multiple disc replacements. Goldstein and et al. Have compared it with ACDF and has reported improved outcome in multiple level disc replacement. Derman et al. Has done study on the evolution of various discs which were available and have reported preservation of the motion at the adjacent level in that. Another study has studied biomechanics and has shown the importance of determining the disc height, positioning, and integrity of the PLL for better outcome. Frank et al. Has studied the inclusion and exclusion criteria and have recommended binding, including more levels can be included. Radcliffe has studied about the cost effectiveness in this meta-analysis, and it has shown that cost effectiveness in terms of preventing recurrent surgeries has a role. Other trials about adjacent disease, adjacent segment degeneration, where it has been compared with fusion. Gao et al. Has reported 2 out of 24, that is 88.3% over a 5-year follow-up. Radcliffe has studied a cohort of 330 patients and reported 50% in disc replacement group compared to 90% in fusion group. That is significant. And adjacent segment degeneration, which required surgery, was 3.1% compared to 11.4% in the fusion group. Landman et al. Reported 4.5 versus 14.7 in disc replacement versus fusion group. Prospective randomized trial compared disc replacement with fusion, 2 level with a particular type of implant, showed improvement in the neck disability index 15% compared to 4% in the other group, maintenance of range of motion after 48 months, and radiologically visualized adjacent segment pathology in 42% compared to 86% in the fusion group. Another meta-analysis by Cho et al. On the biomechanical analysis have studied range of motion, the adjacent segment mobility, and the intensity center of rotation. They've compared it with the hybrid surgery as well, and has shown that ROM is reduced in fusion, it increases in the disc replacement, remains normal in hybrid surgery. Similarly, mobility is increased when it is fused compared to unchanged in both hybrid as well as disc replacement surgeries. Instantaneous center of rotation is more in fusion, and it changes minimally in both, whether it is disc replacement or a hybrid. Now, this is one meta-analysis which combining all available clinical outcomes on cervical disc arthroplasty. It's as a detailed, including randomized, non-randomized, prospective, retrospective trials, and has at least 62 studies which have been included with fusion as a control, and they have stated that the incidence of adjacent segment is around 26% compared to 43.9% in the fusion group, and secondary surgery rates are significantly higher in the fusion group compared to the disc replacement group. So we conclude that multi-level TDR is safe and effective as single-level TDR. Preservation of motion at the index level is achieved. Biomechanical stability to minimize or reduce ASD is achieved. And hybrid surgery may be a worth consideration when there are multiple levels which are involved. Thank you.